So I see some respiratory therapists in the back. A lot of the physiology I'm going to discuss is very basic and certainly not at your level, but I want to go through this so that people understand what the issues are here in terms of the issues of respiratory failure in people with ALS, and what are the things that we can do to support weak respiratory muscles. So it's important to understand the structure and the function of the respiratory system. So in terms of the structure, there's the diaphragm, which, can everybody hear me? Can you guys in the back row hear me? Okay. There's the diaphragm, which is the main muscle of inspiration, which I think most of you know, and then there's the lungs. In people with ALS who don't have other lung diseases such as asthma or emphysema or other conditions, there's nothing about ALS that affects the lungs per se, but ALS does affect the diaphragm. The function of the respiratory system is to bring oxygen into the lungs, which then gets into the bloodstream, and to get rid of carbon dioxide when we exhale. So this is a picture of the lungs, and this is the trachea or the windpipe, which comes down, divides into the right side and the left side. The heart sits here, okay? And these bronchial tubes divide into multiple branches down to a microscopic level, okay, on both sides, ultimately terminating in these little tiny microscopic air sacs, of which there are millions, and they're called the alveoli. The alveoli, every little tiny microscopic alveoli is associated with a tiny blood vessel called a capillary, and that's where gas exchange occurs. That's where oxygen that we breathe in gets into the bloodstream, binds into red cells, binds to hemoglobin, goes to our tissues, provides oxygen, which we're dependent upon, and this is where carbon dioxide, which is a waste product of our metabolism, comes back out from the bloodstream into the alveoli and gets exhaled back out. Underneath all of this is the diaphragm, which is again the main muscle, which allows the whole, is really the pump or the bellows, which allows this whole system to work. So again, the diaphragm is our main muscle, and it is innervated by the phrenic nerve. It contracts, okay, there's a right diaphragm and a left diaphragm. It contracts, it normally sits in a kind of domed position. It contracts, it flattens out, and it allows us to suck air into our lungs. So the lungs expand and air enters our lungs, and with that, oxygen comes in. So that's how we get air in. Yes? What about hiccups? Well, hiccups are abnormal, okay, as anyone who's had them knows. Hiccups are a spasm of the diaphragm, okay? They don't serve a function. They don't allow you to, they're not a method of breathing, but hiccups are a spasm of the diaphragm, basically. But when the diaphragm contracts normally, not in the hiccuping state, we get air and oxygen into our lungs, and once we've inhaled and oxygen's in our lungs, when we exhale, it actually doesn't require, just a normal exhale does not require any muscle strength. Our lungs have elastic tissue in them, so when we've reached a certain point of inspiration, we exhale by what we call elastic recoil. It's like if you stretched a rubber band to a certain point and then let it go, that's how the lungs exhale. They sort of spring back into their neutral position. There are times when we do need muscle force to exhale, though, and that's when we do what's called a forced exhalation, and that would be, for example, when we cough. If you think about when you cough, you take a deep breath in, and then, and that takes muscle strength. The muscles between the ribs, the abdominal muscles, help us with a forced expiration, and one of the most important times we have a forced expiration is with a cough. So oxygen, I said some of this already, oxygen enters those tiny little air spaces, the alveoli, during inspiration. Oxygen gets into those tiny blood vessels, the capillaries, binds to hemoglobin in the red blood cells, and then blood, which contains oxygen, is taken throughout the body to all the different organs, the brain, the kidneys, the muscles, the liver, and allows, metabolism to occur. We are dependent on oxygen to live. Carbon dioxide is something that's produced by normal metabolism in the body, and it is removed from the body when we exhale. There's always a normal amount of carbon dioxide in our bloodstream, but it can accumulate if we can't have a proper exhalation and get rid of it. So, well, I'll get to that. So what happens if the muscles are weak, if the respiratory muscles are weak? And that is what happens in people with respiratory muscle weakness in ALS or other conditions where respiratory muscles are weak. So the things that happen are mostly related to diaphragm weakness, but we can have problems related to other muscle weakness as well. So the diaphragm can become weak just as any other muscle can become weak in ALS. The accessory muscles, the ones I talked about, the muscles like between the ribs or the abdominal muscles, can also become weak. That doesn't matter in terms of taking a breath in, but it can result in difficulty coughing, which isn't a problem unless you need to cough. So the effects of diaphragm weakness can be less muscle strength during inspiration. So what that can result in is a smaller amount of air is inhaled with each breath that a person takes. The smaller amount of air that a person takes results that less oxygen is inhaled on each inspiration, and less carbon dioxide is exhaled with each exhalation. The term for this, for the smaller lung volumes, is called hypoventilation. Hypo meaning less, and ventilation meaning ventilation, or how much air goes in and out. So the term is hypoventilation, meaning underventilate. So the symptoms of diaphragm weakness or hypoventilation are caused by the elevated blood levels of carbon dioxide and by the decreased blood levels of oxygen that, again, are caused by hypoventilation. So some of the symptoms of diaphragm weakness and hypoventilation are the following. One of the first things people might notice is something we call orthopnea. That's a medical term. Orthopnea means shortness of breath when lying flat. So a person may feel fine when they're sitting up, standing up, whatever, but one of the first things a person might notice is that they don't feel comfortable when they go to bed at night. And the reason for that is, if you think about it, that if you're sitting up or standing up, you have gravity to help you. Because again, what happens is that that diaphragm, which is normally like this in sort of a domed position, when it contracts, it flattens out, it pushes down the abdominal contents, and it allows the person to suck air into the lungs. Well, as you can imagine, that's easier to do. Gravity is helpful in terms of that pushing down of the abdominal contents if you're sitting or standing. But it's more difficult to do that if you're lying flat because you lose the help of gravity. You're working against gravity in the lying flat position. The other time that this occurs is when a woman is in the last stages of pregnancy and also can't lie flat because they're trying to push against that big baby that's pushing up against the diaphragm. So one of the first symptoms can be feeling winded or that sensation of not being able to get enough air when lying flat. A consequence of orthopnea or diaphragm weakness can be what we call sleep disordered breathing, meaning that the hypoventilation can be more exaggerated when the person's lying flat and trying to sleep. As I said, increased hypoventilation can occur during sleep, and just even if the person's not sleeping, but if they're, say, lying flat on the couch trying to watch the Phillies or the Eagles. Oh, I'm sorry, Jim, I wasn't going to mention the Phillies or the Eagles. I'm sorry. I owe you a cup of coffee. I'm sorry, Jim. So hypoventilation during sleep can result in very poor sleep quality. Again, that can either be secondary to the decrease in oxygen levels or to elevated carbon dioxide levels. And some of the symptoms of that can be waking up with a headache every morning, poor sleep quality. As some of you may know, we have several stages of sleep, stages 1, 2, 3, 4, and then the stage of sleep that we call REM sleep, which stands for rapid eye movement, REM, which is the stage of sleep when we dream. People that have sleep disordered breathing, whether it's from this or sleep apnea, don't get good quality sleep. They tend never to go into REM sleep. They don't dream. And so even though they may have their eyes shut, they may not be getting good quality sleep. When they wake up in the morning, they don't feel like they got a good night's sleep. They may have a lot of daytime sleepiness and they just don't feel right. As diaphragm, and those are some of the earlier symptoms, again, the orthopnea, the sleep disordered breathing. As diaphragm weakness progresses, people may feel breathless with very minimal exertion, or then even when they're just sitting still or at rest. Symptoms of having a low oxygen level can be headaches, feeling a little nauseated, just feeling tired. Elevated carbon dioxide levels can cause, at their worst, can cause confusion, lethargy, sleepiness. And people may not, put two and two together. People don't necessarily associate that kind of chronic nausea, headachy feeling may actually be from a lung problem, or not a primary lung problem, but from a respiratory problem. They may think it's something to do with their stomach, because that would seem to make more sense if you're, not medically trained. So how do we evaluate for diaphragm weakness? Well, for people who come to the clinic, you guys know that one of the things we do is we do that breathing test, the spirometry, on every visit. And that's not a perfect test. I know sometimes people get very anxious about what numbers are going to look like, and there are some people who just can't perform that maneuver. But that is one of the things we look at. We do that test where you take a deep breath in, blow into the machine, and what we're looking at is the vital capacity, because that can be a good screening tool, but it's not an all-or-one test, but it's a reasonable screening tool for the strength of the diaphragm. The thing about that test, though, is if you think about when you do it, you take a deep breath in. You need diaphragm strength to take the deep breath in, but then you also have to be able to blow out. Well, it takes diaphragm strength to take the deep breath in, but it takes some of those accessory muscles, those rib muscles and abdominal muscles, to force the breath out. So sometimes if the diaphragm strength is decent, but the expiratory muscles are on the weak side, it can underrepresent the diaphragm strength. So that's just one piece of information, and we take it in context with everything else about the person. But it's a helpful piece of information, but it's not an all or none piece of information. Other things we do, if people are telling us that they feel like they're not sleeping well, sometimes we'll ask the home care companies to put a clip, an oxygen that measures oxygen saturation. We'll ask them to put a clip on somebody's finger and measure their oxygen level overnight to see if it's dropping. That's called overnight oximetry. And another thing we can measure is what's called end-tidal carbon dioxide. It's a little prong in the nose that can measure a carbon dioxide level with exhalation. If that's elevated, it can tell us there's elevated carbon dioxide levels. So those are easy ways to evaluate the function of the diaphragm. I kind of already said this about the measurement of the vital capacity. I should mention that sometimes it can be helpful when we're measuring the vital capacity if somebody's telling us they have a lot of symptoms and we measure the vital capacity when the person's sitting up and it seems pretty decent, then we'll sometimes measure it when they're lying down. And if there's more than a 5% difference in the sitting versus the lying position, that can be important. Because as I talked about, often one of the first symptoms is shortness of breath in the lying down, or what we call supine position. And again, these rules are not dogma; they're kind of guidelines. But roughly, if somebody's vital capacity, either sitting up or lying down, is less than 50% of what we call a predicted value, that is a rough correlation with symptoms. It's not an absolute by any stretch of the imagination, but at that 50% range is sort of a red flag for us, but it's not an absolute. The overnight oximetry, I kind of described that already either, and if there's a significant drop in the oxygen level when somebody is sleeping, then that's a sign to us that they may need some support, some respiratory support when they're sleeping. We'll get to that. And the end-tidal carbon dioxide also measures the carbon dioxide level in the exhaled air, which can correlate with the blood levels. And if they're elevated, again, that tells us that maybe the person needs some type of support when they're sleeping. So what are the types of respiratory support? we can talk about BiPAP, which is a trade name. BiPAP is a trade name like Coke or Kleenex or something like that, but it's become the term that we use. What it really means is non-invasive positive pressure ventilation. We have ventilators, which are capable of full support of respiration, and as many of you have probably heard, just approved by the FDA at the end of September, is diaphragm pacing, which is new and not completely understood where this fits in, but I will talk about it a little bit at the end of the talk. Okay, so BiPAP. So what it stands for is bilevel, and by bilevel we mean both inspiratory and expiratory positive airway pressure. So what it is, it's a machine, and I think this will be one of my pictures that didn't turn out, but it's a little tabletop machine that is connected to tubing and a mask. As many of you have probably seen, it's a tabletop machine hooked up to tubing, and then there are different types of masks. This is an example of one type of a mask. This one would just fit over the nose. Sometimes they fit over the nose and the mouth, and then there's something called nasal pillows, which just goes up into the nose. And I think I had great pictures that didn't turn out. Thank you. Again, Steve Jobs. But the whole idea is that, again, we talked about this hypoventilation, that if the diaphragm is weak, the amount of air being inhaled into the lung is not enough. So what BiPAP does is the machine delivers a certain amount of air, not a volume of air, but a certain amount of pressure. So the person initiates a breath, and then the machine gently delivers through an interface, through a mask, delivers a pressure that will then result in an increased amount of air being delivered into the lungs. And that helps support the person's breathing. It doesn't breathe for them, but it helps support their breathing. So it increases the volume of air that the person takes into their lungs with each breath. Most people with respiratory muscle weakness, whether it's from ALS or another condition, start using BiPAP initially at night because, as we talked about, nighttime lying down is usually the time when people begin to have problems for the reasons we talked about. Yeah, that was the picture. So, people who use BiPAP, like I said, usually start using it just at nighttime, or if they take a nap, or if they're lying on the couch, doing whatever. And people don't usually eat while they're using the mask, but it's on and off. People can speak, people can eat. It's an intermittent thing. It's a form of support. It doesn't take over breathing. Most BiPAP units require a plug. It's not considered life, it's not considered life support. It doesn't take over. It's the rare BiPAP unit that has batteries for backup, so they're not terribly portable. This is something that may be changing with technology, but the majority of units really don't have battery backup. Some have car adapters, that can be plugged into car. Well, I guess there's no cigarette lighter outlets, but you know what I'm saying, the power outlets in cars. But anyway, those are BiPAP units. And I think these were just pictures of people with different types of BiPAP masks. The full face mask, the nasal pillows, the nasal masks. Okay, so yes?
One quick question.
Sure.
BiPAP, is it further speed weakening?
No, that's a really good question. And the answer is absolutely not, okay? And it's a really common question. People worry that if they go on BiPAP, that they're gonna become dependent on it, or their muscles are gonna get weaker or whatever. That's if anything, the opposite is true. I'm trying to think of an analogy. I mean, if you had diabetes, you wouldn't not use insulin because you wanted to toughen up your pancreas, right? If you had pneumonia, you wouldn't stay away from antibiotics to, show your immune system that who was boss. You know, same thing with this. If somebody has a weak diaphragm and needs BiPAP, they should use it because, first of all, the consequences of having a low oxygen level and a high carbon dioxide level at night are bad for you. And to have that kind of metabolic derangement is then bad for your muscles. Some people think, I can't say it's been definitively shown, but we've all seen this, is that sometimes when people start on BiPAP, you know, they've had sort of, you know, their muscle function has been sort of in a slow decline. Often when they start on BiPAP, things seem to sort of plateau out. So it clearly does not make people weaker. They don't get dependent on it. It's not something to be avoided, and it's not something that people should feel like they want to tough it out without it. It's there to help. Yes?
By the same token, is it of any benefit to start on a BiPAP sooner than, you know, what insurance might cover at that sort of 50-some%?
That's a good question too. I'm sorry. The question was, is there any benefit in starting it sooner? You know, if somebody gets to that 50% mark, but yet they're not having any, am I saying your question correctly? If they're not having any symptoms and there's no objective finding of trouble, is that what you're asking?
Or even if they're having mild symptoms?
Well, if somebody's having symptoms, then they should use it. You know, if somebody's having symptoms, if somebody's having shortness of breath at night or their oxygen level is decreasing, then they should use it. You know, I mean, if you're having symptoms and the vital capacities at 50% or lower, then there's no reason not to use it. I mean, if the vital capacity is, you know, sort of 45 to 50%, and there's absolutely no symptoms, and the overnight oximetry is normal, you know, sometimes we'll prescribe it so that people can kind of get used to it. Sometimes there's a little bit of time for people to adjust to the comfort of the mask, et cetera. But there's certainly no, I mean, if somebody's vital capacity is, you know, 70% and they feel fine, there's no benefit to starting early. Okay, are there any other questions about that? Okay. So moving on to ventilators, which are different than BiPAP in that they are, you know, whereas we consider BiPAP non-invasive ventilation, and we say non-invasive because these masks are considered non-invasive. They can be taken on and off. People can, you know, speak, they can eat. A ventilator is sort of another step up. They're more invasive and more technologically sophisticated. So a ventilator is a machine, and I think there'll be a talk later from Respironics about one of the types of ventilators, but it's a machine, also very small now with our advanced technology, that rather than delivering a pressure, which is what the BiPAP or the non-invasive ventilation delivers, a ventilator delivers an actual volume. It delivers an amount of air. It delivers a certain number of breaths a minute, and it is considered complete life support. So with a ventilator, it is considered invasive. A person who's on a ventilator has a tracheostomy. It's not delivered through this type of a mask. And most people, not everybody, but most people who require a ventilator for respiratory support are usually on it 24 hours a day. Now again, that's not always the case. There is the occasional person who requires a ventilator and may be able to be off it for some time during the day. But I would say that the majority of people who reach the level of respiratory muscle weakness that they require a tracheostomy and a ventilator, majority of people who are in that situation are using it 24 hours a day. I would say that virtually everyone who's using a ventilator for respiratory support has a feeding tube because it's generally not possible to chew and swallow and sustain adequate nutrition without that. So most people have a PEG tube or a feeding tube in the stomach, either beforehand or simultaneously with the ventilator. And as I said, it's connected to the patients via a tracheostomy, and I'm not sure if which of these pictures came through. Okay, so just the idea of the tracheostomy, this is just a picture. So obviously this is a person. Up here is the larynx. The vocal cords are up in this area, in the larynx. And this comes down, and here's the trachea, the windpipe, which remember we saw in the earlier picture. And the tracheostomy tube is placed around in this area, kind of where this arrow is. And okay, that's a good, this one came through also. So the incision is made right around here, so again, below the vocal cords. And that one didn't come through. And it's not the best picture, but you can get the idea that this is the the other picture I think was of tubes. The tracheostomy sits here. There's usually some padding underneath here, and then there's kind of a strap around the neck. And this is the tracheostomy tube, and then it's connected to this tubing, which then is connected to the ventilator. Okay, so there's nothing on the person's face. There's no more mass. There's nothing on the face, but the ventilator's here. So the ventilators themselves come in different sizes. Some can sit on a table. They're really pretty small now. Some are and the thing about ventilators, unlike BiPAP, is that they do have portability. They do have backup batteries. Most of them can kind of hang on the back of a wheelchair, which I think I do have a picture of, and allow, actually for most people, more portability and more mobility than a BiPAP machine does. Again, people generally can't eat normally with a ventilator. The tracheostomy tube has, again, it goes in here and it's down. There's actually a little balloon cuff on the tube. So again, I apologize, I had a picture of this. The balloon cuff is blown up so that the tube is a plastic tube, and then there's a little balloon cuff on it so that the trachea, so the trachea is occluded, so there's no air. All the air is going in and out through the tracheostomy tube. If you think what it takes to speak, when we speak, we have to exhale air past our vocal cords. So if you try to talk when you're inhaling, you can't. You can only speak when you're exhaling, and we exhale air past our vocal cords. So the reason people can't speak on a ventilator is because there's no air passing by their vocal cords, because all the air is going in and out through the tracheostomy tube. So people generally cannot speak normally. There's other methods of communication, which you'll hear about later today, but traditional speaking is generally not possible on a ventilator. And again, eating, same thing. One of the reasons is that generally, in this disease with ALS, many people, if not most people, if they've developed enough diaphragm weakness to require a ventilator, odds are their swallowing is probably not very good either. So that's one of the main reasons that people don't eat when they're on a ventilator, is that probably their swallowing is not good either. But the other thing is that when that balloon cuff is blown up, the back of the trachea sits in front of the esophagus, and that in itself can make swallowing more difficult. So generally, when people are on a ventilator, they have a feeding tube in their stomach, because there's no way that a person on a ventilator could eat enough to adequately support themselves nutritionally. So speaking traditionally, I'm not saying people can't communicate when they're on a ventilator, but speaking traditionally is generally not possible, and eating normally is generally not possible, but nutrition is provided in other ways. That's an old ventilator. They really don't look like this so much anymore. That's a newer one, and that can kind of hang on the back of a wheelchair. And oops, wait a minute. And that's a good picture of sort of a wheelchair with a ventilator. Obviously, that's the ventilator hanging on the back. Ventilators are capable of full support. Somebody who has essentially zero diaphragm function can live with the full ventilatory support of a ventilator. It can really take over the capacity for somebody who is unable to breathe on their own at all. A person who is on a ventilator requires that somebody be with them really 24 hours a day. And it can't be the same person, obviously, because nobody can be awake and caretaking for another person 24 hours a day. The machines aren't complicated, but there's a learning curve, and they have alarms. For example, if the ventilator connection popped off the tracheostomy tube, an alarm would go off, and the person taking care of the patient would need to know what that alarm meant and respond to it and hook the person back up, because you could imagine if for some reason that popped off and it wasn't recognized and the person on the ventilator wasn't able to tell them, that could be a devastating consequence. People on ventilators have mucus, just like all of us have mucus, and require suctioning, and I think those are some of my pictures that didn't turn out, but there are small suction catheters that are connected to the tubing that need to be passed down through the tracheostomy tube into the airways, several times a day and have mucus sucked out. Occasionally, those secretions can get thick or cause plugging. If a glob of mucus gets stuck, that'll cause an alarm on the ventilator. Again, the person with the person on the ventilator needs to know what that alarm means, needs to know how to suction, needs to be able to read the controls on the ventilator and respond to different things. And again, none of this is extremely difficult, but it requires training, it requires a learning curve, and somebody needs to be awake and available 24 hours a day, 365 days a year to be available to monitor this. And that comes into issues of home care, which I think, again, will be addressed in other talks today. Just other pictures. Okay, so to discuss a little bit about diaphragm pacing. So is there anybody in this room that hasn't heard about the diaphragm pacing? I didn't think so. Okay, so I wish I could give you, complete ins and outs. A lot of us who work at the clinic have heard several talks on this over the past several years. So as you probably know, this was approved by the FDA just a few weeks ago on February 29th. The researcher who has been working on this since 2004 is Dr. Raymond Anders. He's at University Hospitals or Case Western out in Cleveland. He's a surgeon, actually, so it's interesting. He actually, I think, started his career as a trauma surgeon. And his sister had ALS, which I assume was one of his main motivations in looking into this. And he actually has a company. It's called Synapse Biomedical, and the website is right there, and it's in your handout. And actually, it's interesting. I have looked at this up and down on the internet, and it's interesting because really most of the information about the system is on his website. I have not been able to find a recent, meaning earlier than 2005, sort of peer-reviewed scholarly article on this, because I think he's been focusing so much on getting this through the FDA. This was actually approved a few years ago now, 3 or 4 years ago now, for patients with spinal cord injury. He's been trying to get it through the FDA for patients with ALS, and it was approved for patients with spinal cord injury a few years ago. And it appears to me, and this is my own conjecture, I think when he started off, his hope was that this would replace BiPAP and significantly delay the time to needing tracheostomy and ventilator. And I think as it has worked out, he's had to narrow the group of people that the FDA approved this for. And I want to make one point. The FDA approval was called humanitarian exemption. Probably another term for this is compassionate use. So it's a little different than a true FDA approval. And part of what it means, because Dr. McCluskey's been looking into this pretty heavily at Pennsylvania Hospital, because he does want to start a program there for inserting the diaphragm pacemaker. And what it's going to mean at Pennsylvania Hospital, since the FDA approval is this humanitarian exemption, that it's still going to have to go through an IRB, or what that means is an institutional review board. It's still going to have to be handled as a study. So it's going to be a little bit complicated. So this is just a picture again. So just remembering, this is actually not the greatest picture, but this is going to be pacing the diaphragm, of which there are actually two. It's not one continuous muscle. What's going to happen, what the process is there's going to be 4 electrodes, okay? So 2 electrodes on the left diaphragm and 2 on the right, and they're going to go on the underneath side, so really on the abdominal side of the diaphragm. And so there's going to be 2 electrodes on the underside of each diaphragm, and then there's going to be a small wire that comes out with a little control box. And then the key thing is, and this is where the company I think is going to be very important to the centers who do this, then it has to be programmed for each person. And well, anyway, so that's how it's going to have to work. Just to tell you the study, what they did is this FDA approval was based on this. There were 86 patients with ALS that were studied at 9 centers. 8 of the centers were in the United States and 1 was in France. The closest center to Philadelphia was at Johns Hopkins. and the rest of the centers were scattered across the United States. One was obviously in Cleveland at his place, University Hospitals. One was in Texas, and you can look on his website and find the rest. I think one was in San Francisco. The requirements were that the vital capacity had to be between 50 and 85%. Now, I think that that's not how he started off. I think he started off doing people with lower vital capacities, and what they found was it didn't work. And what this really means is that the people for whom this was successful had to have an intact phrenic nerve and a fairly functional diaphragm at the time of the electrode implementation. Because if the diaphragm was already atrophic and essentially not functioning, then there weren't intact muscle fibers for the electrodes to pace. So if you just think about this in a fairly simplistic point of view, nerves innervate muscles, okay? And it's an electrical connection, okay? But if the muscle that the nerve or the electronic pacemaker is already atrophied and can't pick up the connection, then it won't work. So for example, we've gotten a lot of calls from patients who are already on ventilators or patients who are very close to requiring ventilators, and very sadly and unfortunately, this situation is not for them. So I think as he sort of sifted out the patients for whom this was helpful, this was the group. People whose vital capacities were between 50 and 85%. You're thinking 85%, that's normal. But this is the group for whom it was helpful. The phrenic nerve had to be intact on both sides, and there had to be evidence that the diaphragm worked bilaterally. And then, as I said, there were 4 electrodes placed on the diaphragm, 2 on each side. There's an external control box, and then after the surgical procedure, which was pretty straightforward, it was done laparoscopically. Hardly anybody, I think one patient had a complication out of 86. It was done quite safely, which was good news. And then the pacemaker was adjusted afterwards. That was a picture of the thing. This was important also. In his very early studies, he was very anti-BiPAP, and I think, again, as he went on, realized that to put in the pacer but not use BiPAP didn't work. So all the patients still used non-invasive ventilation along with the pacemaker. And the results were that the patients with the pacemaker plus the BiPAP survived about 16 months longer with the pacemaker and BiPAP than people who used BiPAP alone. And when they say survived, the definition of survival was from time to diagnosis until the need for tracheostomy and ventilator, or until they passed away. And that was using historical controls, not a specific control group parallel in that study. And one of the most notable things is that the patients said they slept much better. The patients who had the pacer said they slept much better with the diaphragm pacer. So the burning question, obviously, is this available now? Is it available in Philadelphia? It is not yet available in Philadelphia. As I said, this has to go through what's called IRB approval, the Institutional Review Board. Dr. McCluskey is, I think the day after this came out, he's been on the phone. There are surgeons at Pennsylvania Hospital. It's not a difficult surgical procedure. That's I'll be with you in a second. It's not, learning the surgical procedure is the easiest part of all of this. But I think it is gonna have to go through the IRB. And there's every intention of beginning this at Pennsylvania Hospital, and I wish I could give you a time frame, but I honestly can't. I think the important thing is, this is exciting and people are very enthusiastic about it. I think when in medicine, and I'm not just saying about this, I think it's very important when anything new comes out, any new technology, that people do things, no matter how excited they are, that people do things correctly. And I'm hopeful that across the United States, that people do this in the same way. It was only 86 patients, that people do this in the same way so that they can compare and make sure that they learn from it and go forward. Because we all know that every time something new in medicine happens, that what happens to the next 500 people isn't always the same as what happened to the first 86. And again, there is every intention to have this done at Pennsylvania Hospital. I cannot give you a time frame. I think the company's feeling is that they wanted to ramp this up initially at the study centers, which kind of made sense. Again, Hopkins is the closest one, and I would say that if anybody is interested in now, that probably calling Hopkins is the best thing, because I cannot say to you that this will be available at Pennsylvania Hospital next week, because the reality is that it can't be because of the things I've just said. So I know there's a lot of questions about that, and there's probably more questions than answers at this point, but I'm sorry, you had your hand up. Did I answer it? Okay. What, that it's not available next week? I wish it were.